in for a real treat today. Getting a lot of information on the elbow, the hand, and the wrist can be a little tricky because there's so much information out there on the shoulder and the knee. Outside of the shoulder and knee, finding anything on say, the hip or foot and ankle or the wrist, hand area is kind of tough to come by. So what we've done is we've partnered with Dr. Awan and his and how he kind of does things here to share with you and make it available for you to look at in the future.
I'd like to thank everyone for joining us for this webinar. As Daniel mentioned, my name is Awan. My background is family medicine sports, but I currently work in the orthopedic department. We treat a lot of musculoskeletal and sports injuries. And I've been doing ultrasound. I got into it near the end of my fellowship, so I've been doing it since I started my practice. I've probably been doing it for about 6 years. I've been teaching it probably for the past 3 years or so. And it's a big part of my practice, both diagnostically and with interventions. I practice in an orthopedic group, so a lot of my colleagues will refer patients for all sorts of procedures. We do procedures basically from the upper extremity on down to the lower extremities, knee, ankle, basically do the full gamut. I also help take care of the Detroit Red Wings. I'm an associate team physician. We actually utilize it quite a bit in the training room, especially during playoff time. We'll do diagnostic scans on players after the games, and we'll even do blocks, anesthetic blocks for those players that need them before the game. So it's a huge component of our practice. So as Dan mentioned, we're going to talk about elbow, wrist, and hand injections. The elbow, wrist, and hand is an enjoyable area to do ultrasound-guided interventions. Many of the structures are superficial, and there's a wide variety of procedures that can be performed because there are multiple tendons, joints, and nerves that are easily visualized. So we're going to start off on the lateral aspect of the elbow. And one of the most common injections performed is for lateral epicondylitis or lateral epicondylosis. Obviously, this is a very common cause of lateral elbow pain and a condition that anyone that practices not only musculoskeletal but in primary care will see quite a bit of. The area of pathology involves the common extensor group. So here's an anatomy schematic here. So on the upper left here, you can see the probe placement. So when you're looking at the common extensor tendon, you can place one end of the probe over the bony landmark of the lateral epicondyle, and you're going to span the radiocapitellar joint. So here's the skeleton diagram here. Once again, you see the distal humerus. Here's the lateral epicondyle. Here's the radial head. This is the radiocapitellar joint. And the common extensor tendon, as you will see here on this schematic, will actually span the joint to its origin on the common extensor, or the common extensor tendon to its origin on the lateral epicondyle. So here's another ultrasound schematic. Once again, we see the probe placement, the elbow slightly flexed. One end of the probe is going to be on the lateral epicondyle. We're going to span the radiocapitellar joint. And here's the ultrasound schematic. So you see here the bony acoustic landmark of the lateral epicondyle, the bony acoustic landmark of the radial head. This recess here is the radiocapitellar joint. And you can see this hyperechoic fibular structure here, which is the common extensor tendon, which spans this joint to its origin on the lateral epicondyle. So you can see here this tendon normally is hyperechoic fibular. There's an area here which is hypoechoic, which is different than you see the surrounding hyperechoic tissue. So this may be an area of pathology or tendinosis. There we go. So this is the setup for the injection. So once again, this is probe placement. It's going to be on the long axis of the forearm. One end of the probe is over the lateral epicondyle. This probe will span the radiocapitellar joint. And you're doing what's called a long axis or in-plane approach where you see the full length of the needle. Here's the corresponding ultrasound video clip. So you have the bony acoustic landmark here of the lateral epicondyle. Here's the radial head. This is the radiocapitellar joint. And you can see this is the hyperechoic fibular pattern of the common extensor tendon. And you can see a needle coming in plane on the distal aspect of the common extensor tendon. And you can see some of the injectate here descending some of the tissue here. There we go. All right, so we're going to stay in the elbow region, but we're going to move to the medial side. There's another tendon that is commonly injected in the medial elbow, of course, the common flexor tendon, and that procedure is done with a similar setup to the common extensor tendon we just looked at. So now we're going to look at the ulnar nerve as a potential source of pain caused by compression in the cubital tunnel. Ulnar nerve minor neuropathy can cause pain and paresthesia in the ulnar aspect of the arm, and it can radiate to the 4th and 5th digit. There we go. So the ulnar nerve courses down here, the upper arm, and it enters the cubital tunnel. So it comes down here, enters the cubital tunnel. There are two very important bony landmarks that are used for ultrasound evaluation of the cubital tunnel. One is the olecranon process of the ulna. The other is the medial epicondyle. So when you're evaluating the cubital tunnel with ultrasound, you place one end of the probe over the medial epicondyle, one end of the probe over the olecranon process. That'll span the cubital tunnel. And you will see the ulnar nerve in cross-section or short axis. Oftentimes, nerves in cross-section or short axis have a honeycomb appearance. So again, here's the ultrasound depiction. So here's, once again, looking at probe placement. One end of the probe is over the olecranon process. The other end of the probe is over the medial epicondyle. You'll span the cubital tunnel, and we'll see the ulnar nerve in cross-section. So again, here's the olecranon process. Here's the medial epicondyle. This structure right here is the ulnar nerve. Oftentimes, nerves are honeycomb appearing, but the ulnar nerve sometimes in the cubital tunnel could be hypoechoic because there's a lot of hyperechoic connective tissue surrounding the nerve. So a lot of times it may be more hypoechoic than that typical honeycomb pattern. So this is the setup here for the injection. There's a couple ways you can do it. You can position the patient in kind of this upside down L position with the elbow flexed and the volar forearm facing the clinician. Again, you're going to have one end of the probe over the olecranon, one end of the probe over the medial epicondyle. A lot of times this is done as an in-plane approach or long axis, so we'll see the length of the needle. And you could either enter from the medial epicondyle towards the olecranon or from the olecranon towards the medial epicondyle. Alternative way of doing this is having the patient laying down. Oftentimes I'll do this because especially when you're treating athletes, a vasovagal response is common. So I have the patient laying on their back and with their arm up above their head similar to a pitching position. And that'll put the cubital tunnel in a nice anterior position. So coming down here to the video clip of the procedure, once again, we're spanning the two bony landmarks. We have the bony acoustic landmark here of the olecranon, bony acoustic landmark of the epicondyle. We can see this hypoechoic to honeycomb appearing structure here. This is the ulnar nerve in the cubital tunnel. So the injection is approaching here from the medial epicondyle towards the olecranon. So you can see the length of the needle. This is a long axis approach, and you're coming towards the ulnar nerve here. All right, so jumping back to the lateral aspect of the elbow, we're going to look at another nerve that's oftentimes in the differential for lateral elbow pain, and that is the posterior interosseous nerve, which is a branch of the radial nerve. The posterior interosseous nerve is purely a motor nerve, but it can be a source of pain when it becomes irritated or compressed. So here is a drawing of the anatomy here. So if you're doing an ultrasound examination to follow the radial nerve, a lot of times you're going to start at the anterior elbow joint. You're going to place the probe perpendicular to the long axis of the forearm. You'll see the nice bony acoustic landmark deep of the elbow joint itself. So a lot of times you're going to use two landmarks which are muscle. You're going to use the brachialis and the brachioradialis. And in the fascia plane between two muscles is the radial nerve, and you could easily delineate that. So you'll start at that area, and then you'll follow the nerve distally where it will divide into a superficial branch and a deep motor branch, which is the posterior interosseous nerve. So a lot of times the deep motor branch will pierce the supinator muscle, and there's a fibrous band that sits here on the superficial aspect of the supinator muscle, and that is the arcata feroce, and that's often a site where the posterior interosseous nerve can become entrapped. So again, here's a schematic. Here's a posterior elbow. Here's the tip of the olecranon. Here's the triceps tendon. And you can see here the radial nerve splitting in a superficial and deep branch. Clinically, when you're evaluating patients for this, a lot of times they'll have tenderness about 4 finger breadths distal from the lateral epicondyle. So here's the lateral epicondyle. They'll have tenderness about 4 finger breadths or 4 to 5 centimeters from the lateral epicondyle. Here's a corresponding ultrasound. So the probe is going to be placed perpendicular to the long axis of the forearm. It's going to be slightly distal to the elbow joint, so you want to try and find bone. So this is going to be your main bony landmark is going to be the radius. You're going to see the bony acoustic landmark here of the radius. And then the next structure superficial to that is going to be the supinator muscle. The supinator muscle has a deep head and a superficial head. And as the nerve courses distally, it will lie in a plane right here. So here's the nerve. It lies in the plane between the deep and superficial heads of the supinator. And there's the overlying brachioradialis that sits on top of this. So you would start off at the elbow joint at the radial nerve, follow it distally to where it splits, and then you can follow it as it dives into the supinator. So here's the injection approach. As I mentioned earlier, the probe is going to be positioned perpendicular to the long axis of the forearm. The approach you're taking is from lateral to medial. It's going to be in plane, so you can see the needle in the long axis. And you want to come in here in this fascial plane between the superficial and deep heads of the supinator. The nerve is right in this area, so you want to come in and dissect that fascial plane. So again, you have your bony acoustic landmark here of the radius. You have the deep and superficial heads of the supinator. You got the overlying brachioradialis. Is that better? And then you see here going from lateral to medial, coming in between the superficial and deep head of the supinator. All right, as we continue our procedures around the elbow, we looked at tendons and nerves. We're going to finish up with the elbow joint itself. Intra-articular injections of the elbow are commonly done in the setting of effusion, synovitis, osteoarthritis, symptomatic plicas. We also use it quite a bit as a diagnostic tool to help determine if the source of pain is intra-articular or extra-articular. So here's the elbow joint anatomy. For doing an intra-articular injection, there's a couple of approaches you can use. There's a posterior approach. You have the distal humerus and the trochlea, which articulates with the olecranon process. So you can go in here in this posterior joint recess. This also articulates with the olecranon fossa. You can also inject at the radiocapitellar joint. So right here, and this is similar to when we looked at the common extensor tendon here. You're going to span the radial head and the capitellum, and there's a joint recess here. So you can come at this either laterally, or you can actually even inject it anteriorly if you so choose. So again, this is the the corresponding ultrasound diagram to the posterior approach. Once again, to our anatomy slide here, we see the humerus. This is the posterior aspect of the trochlea of the humerus. This is the olecranon. Here's the radial head. So for the posterior joint recess, you'll come in this area. Here's the corresponding ultrasound anatomy. You have the bony acoustic landmark here of the distal humerus. This structure here is the olecranon fossa. Here's the olecranon fossa itself. This hyperechoic fibrillar pattern, this hyperechoic fibrillar structure here is the triceps tendon. It comes over here and attaches on the olecranon. Back here to this olecranon fossa, there's a fat pad here, and when you look at an X-ray and you see that posterior fail sign or that posterior fat pad sign, what that is when fluid enters the olecranon fossa, it'll displace the fat pad posteriorly, so that's why you'll see that fail sign. So a lot of times when you're injecting the posterior joint, you can come in here from proximal to distal. You could enter the ulnar humeral joint here posteriorly, or you can even enter the olecranon fossa. And no matter where you inject, it will get intra-articularly. And this is looking at now doing the radiocapitellar injection. And again, as we mentioned earlier, it's similar, and it's going to be a similar position as you look at for the common extensor tendon. We're going to span the bony acoustic landmarks of the capitellum and the radial head. So coming over here to the ultrasound diagram, we have the bony acoustic landmark here of the capitellum. You can see the typical contour here in the bony acoustic landmark of the radial head. We have a hyperechoic fibrillar structure that spans this region. This is a common extensor tendon, and this gap here is the joint recess. You can see a little bit of extension of the joint recess. So this is the approach for the injection. So this is first of all looking at the posterior approach. So again, the probe is going to be in long axis to the, it's going to be parallel to the long axis of the humerus. You're going from proximal to distal. Once again, our bony acoustic landmark here of the olecranon fossa of the trochlea. This is the olecranon itself. So you can see the needle coming in from proximal to distal into the posterior ulnar humeral joint. You can see when the fluid is injected, you can actually see the injectate tracking down here to the olecranon fossa. So you could very well come in here and inject into the olecranon fossa, and the fluid will track into the joint itself. So this is often done long axis, so you're seeing the length of the needle. Oftentimes, if you're doing the injection from the radiocapitellar joint, it's done using what's called a short axis or out of plane approach. So the needle is actually going to be perpendicular to the beam of the ultrasound. So this is probe positioning, similar to looking at the common extensor tendon. We're going to span the radiocapitellar joint. So you can see here, this is the bony acoustic landmark here of the radial head. This is the capitellum. So the needle is going to come in perpendicular to the beam of the ultrasound, so it's just going to appear as a dot that we saw here earlier. Here's a dot. So a lot of times you may want to inject more superficial just to make sure it's centered, and then you would do what's called a short axis walk down. So you'd make sure you're centered over the joint and then walk down into the joint. And you can see some of the injectate going here, just in the joint recess. All right, moving down the forearm to the wrist. The dorsal recess of the wrist is an area that's used to treat intra-articular wrist pathology. Similar to the elbow, injections of the wrist joint are typically done for arthritis, gout, pseudogout, or synovitis. The wrist anatomy can be a little bit busy. We're going to focus mainly on the dorsal recesses. There's a lot of carpal bones, ligaments, and tendons here, so sometimes it can get confusing. But the main areas we want to focus on here for the dorsal recess anatomy is the radiocapitellar joint, which is the recess formed between the distal radius and the proximal carpal row. There's also, so here's the proximal carpal row here. There's also a mid-carpal recess that forms between the proximal carpal row here and the distal carpal row here. So a lot of times when someone says they're going to do an intra-articular wrist injection, they basically inject here in the radiocarpal joint. Move on here. So here's a corresponding ultrasound anatomy diagram. So again, the probe is going to be placed in long axis to the forearm. We're going to span the radiocarpal joint. Here's the corresponding ultrasound. This is going from proximal to distal. We have the bony acoustic landmark here of the distal radius. We have a bony acoustic landmark here of the proximal carpal row. In this case is the lunate. And we have a bony acoustic landmark here of the distal carpal row, which is the capitate. So there's a proximal carpal recess here, which is the radiocapitellar joint. There's also a mid-carpal recess here in between the proximal and distal carpal rows. And so you can see it here between the lunate and the capitate. So again, you want to make sure the probe spans the radiocapitellar joint. And a lot of times you're going to see this step off between the bony acoustic landmark, and this usually indicates a bony recess. And you can see one of the hypercoic fibrillar pattern of the extensor tendon coming above. So a lot of times when you're doing a wrist injection, a short axis approach can be used. Again, this is probe positioning. You're spanning the radiocapitellar joint. We're a little bit more radial here, so you can see the bony acoustic landmark of the radius here. And there's a little gap here, and then you see a bony acoustic landmark here of the scaphoid. So again, you can see here in this schematic here, this is short axis, so the ultrasound beam is going this way. The needle's coming in this way perpendicular, so you're going to see the needle as a dot. And a lot of times you want to start a little bit more superficial, make sure it's centered over the joint, and then you want to drop the needle down into the joint. So again, you see extensor tendon here. You see the characteristic bony acoustic landmark of the distal radius. There's a little step off which indicates the radiocarpal joint. Then you see the scaphoid. A lot of times if you get lost, you can start a little bit more proximal here over the radius and then just move you'll see this characteristic bony acoustic landmark. It's really easy to get lost in ultrasound, so bone is your friend. So a lot of times you want to use bone as a landmark. So you'll start more proximally and work distally. And the first gap you see is going to be the radiocarpal joint, or the first, or the wrist joint itself for injection. All right, so another area near the distal aspect of the wrist that can be a source of the pain is the first CMC joint. CMC arthritis is the most common arthritis that affects the hand. This area is the articulation between the base of the first metacarpal and the trapezium. So again, here's an anatomy depiction. So you got the first metacarpal here, and it articulates with the trapezium. So a lot of times people can get arthritis, and this joint is called basilar arthritis or basilar thumb arthritis. Another thing to keep in mind is there's also another joint here in the basilar thumb that can be a source of arthritis, and this is this joint here between the scaphoid and the trapezium. So oftentimes we may not just be injecting the CMC joints. Sometimes it's clinically indicated and based on exam. They have pain in this area as well. We may inject this joint here between the scaphoid and the trapezium. But this is going to be the main area here, the base of the first metacarpal articulating with the trapezium. So again, here's a ultrasound anatomy depiction. So when you place the probe, you're going to place it along the long axis of the metacarpal, and then you're going to see these, again, bone is your friend. You can see this characteristic bony acoustic landmark of bone. So you're going to see bone, step off, bone, step off. So these step off are the joint recesses. This right here is the base of the first metacarpal. This here is the trapezium. This here is the scaphoid. So there's going to be bone, step off, bone. This is a recess here, and then bone, step off, bone. This is a recess here. So a lot of times when you're injecting the basilar thumb, you can go in short axis or long axis, and your target's going to be this recess here in between the base of the CMC and the trapezium. And oftentimes this can be a source of quote-unquote wrist pain, but you see the joint is kind of in this area, so it's close to the radiocapsular joint. So a lot of times patients can come in complaining of pain close to the wrist in that area, so you have to make sure you do a thorough exam. So again, here's a depiction of the injection. You can go out of plane or out of plane. So again, here's the carpal metacarpal joint. Here's the trapezium. This articulation is the CMC joint. You can go in plane along the long axis of the metacarpal. You can go out of plane here, perpendicular to the beam. So here's a video clip of the long axis approach. Here's the metacarpal here. Here's the trapezium, and you could see the in plane or the length of the needle coming in and going into this articulation. You actually could see the injectate, some air bubbles coming here in the CMC joint. So the alternative approach is the out of plane or short axis approach. So again, the needle is going to be visualized as a dot. It's going to be perpendicular to the beam of the ultrasound. Over here we have the shaft or the long axis of the metacarpal. Here's the trapezium. This little recess or divot is the CMC joint. So a lot of times you want to try and get your needle tip right into this recess. A lot of times these joints, the nice thing about doing procedures under ultrasound, a lot of times these joints will have a capsule. So a lot of times with an arthritic joint, you may not be able to get it within the joint itself, but you just need to be under a capsule that overlies the joint, and the medicine will leak intra-articularly. All right. Now we're going to move on towards the carpal tunnel. We have injected some nerves around the elbow, and now we're going to look at the nerve at the wrist within the carpal tunnel. This is the most common mononeuropathy that we see in clinical practice, and of course it affects the median nerve. So this is an anatomy depiction of the wrist. As you know, the carpal tunnel consists of the median nerve, which is right here. There are 8 flexor, so there's 9 tendons total. There are 8 flexor tendons, 4 from superficialis, 4 from profundus, and you have the flexor pollicis longus here. The floor of the carpal tunnel is made up by the carpal bones. You can see here the pisiform, which is an asterisk. In the roof of the carpal tunnel is the transverse carpal ligament or the flexor retinaculum. The proximal attachment over here of the ligament is the scaphoid on the radial side and the pisiform ulnarly, and this extends distally to the trapezium radially and the hook of the hamate ulnarly. So we'll go on here to the ultrasound anatomy here. So you're going to place your probe perpendicular to the long axis of the wrist, so it's going to go across this way. And nerves so the nerve is going to be in cross section or in short axis, so you can see it has this typical honeycomb appearance. Nerves in ultrasound on short axis tend to be, but the nerve fascicles are hyperechoic, but it's surrounded by a hyperechoic connective tissue or the epineurium, so that's why you get this characteristic honeycomb appearance. So this is the radial side of the wrist with the scaphoid. Here's the ulnar side with the pisiform. You can make out here the 8 flexor tendons. The 9th tendon here is the flexor pollicis. You can see here this is the flexor retinaculum that goes over across here. So a lot of times when you're injecting the carpal tunnel, you can go either from the radial side or the ulnar side. You want to go long axis, so you want to see the length of the needle. You want to be careful whether you go radial or ulnarly to find the vessel. There's an ulnar artery and a radial artery, so you want to make sure you find that and make sure it's not within the trajectory of the needle. So this is the video here. The injection, again, the probe is placed perpendicular to the long axis or parallel with the wrist crease. This is a radial approach. So again, you're going to see the honeycomb structure of the median nerve. This is the carpal bone here, the lunate. So this approach is going from radial to ulnar. Oftentimes with nerves, we do what's called a nerve hydrodissection. So what you can do is when, this is the beauty of ultrasound, what you can do is use the pressure of the fluid to separate nerves from the surrounding structure. So you see here in this diagram, the needle's coming underneath the median nerve, and you're doing a dissection of the nerve from the surrounding flexor tendon. So you can see how that separates nicely. I'll go back to that over here. So you can see the pressure of the fluid. So sometimes if people have adhesions, a lot of times this dissection can help release some tissue. So you would go underneath the nerve, and then you would go above the nerve. All right, so the final injection we're going to look at here is the flexor tendon sheath. This is commonly done for trigger finger stenosing tenosynovitis, which is a mechanical catching of the flexor tendon at the level of the A1 pulley, which sits at the metacarpal phalangeal joint. We got another diagram here that depicts the anatomy. So again, you have the flexor tendon, and it's in a sheath. So a lot of times they have tenosynovitis of this area. There's a sheath that surrounds this 360 degrees. There's the A1 pulley here. This is at the level of the metacarpal head or the MP joint. So sometimes with stenosing tenosynovitis or trigger finger, the tendon sheath will become inflamed and thicken. The A1 pulley can become inflamed and thicken, and you get mechanical catching, triggering, and pain at this area. A lot of times in clinical evaluation, patients will have, you'll actually be able to palpate a nodule here at the A1 pulley, and that's usually the area where they'll feel most of their pain. So here's the ultrasound schematic. So the probe is going to be in the long axis of the finger. Once again, you're going to see the bony acoustic landmark here of the metacarpal. There's a little recess. This is the proximal phalanx. So this is the MP joint. You see the hyperechoic fibular pattern here of the common flexor tendon. And you see this hypoechoic structure here, usually right above the metacarpal head. This is the A1 pulley. So a lot of times if this is pathologic, you see this thickened. So your approach is going to be from distal to proximal. You're going to advance the needle until you get in the flexor tendon sheath, and you want to distend the sheath. You can also look at this in short axis and make sure there's a halo around the tendon sheath. So this is the corresponding video clip. So again, this is the approach. You're going from distal to proximal. You're going to be in the long axis of the shaft of the metacarpal. So this is the metacarpal head. This is the joint recess. This is the proximal phalanx. So this is the MP joint. You see the hyperechoic fibular structure here of the flexor tendon. You see this hypoechoic structure here, just superficial to the metacarpal head. This is the A1 pulley, and you can see the needle coming in the flexor tendon sheath. Then you want to distend the sheath. So this can be done for trigger finger stenosing tenosynovitis of the flexor tendon. All right, so I think that concludes our talk on the ultrasound-guided injection.